Okay, welcome back. Let's see if we can make it through the whole class before it shuts down on us again. So we're going to pick up where we left off. We had talked about how to complete an assessment of the individual with urinary incontinence or voiding dysfunction. We talked about the importance of a comprehensive interview focusing both on the patient's description of the problem and on a review of systems. We talked about the importance of conducting a medication review, an environmental scan, possibly a cognitive evaluation. We talked about the critical aspects of a physical assessment, and then we talked about essential labs, urinalysis, post-void residual for selected patients. And we discussed situations in which urodynamics would be indicated and information provided. So now we're to the point where hopefully we have all of our data. We're trying to put it all together and establish a management plan. In the last class we talked about, first of all, identifying conditions that would require referral or immediate treatment. We talked about going back through our data to determine operational reversible factors, and we talked about strategies for correcting those reversible factors. So now we're going to talk about how it is that you determine the type of incontinence and then move forward with the treatment plan. So what you want to do is you want to reevaluate the patient after you've corrected reversible factors. Typically, you'll send them away with initial management recommendations. That might be a bowel program. It might be starting them on topical estrogen therapy. It might be a 2 to 3 week trial of caffeine reduction and reduction of other irritants. It might be some modifications in their medications, a number of things that could be put into place based on their specific reversible factors and any conditions that required immediate treatment. Then you're going to want them to complete another bladder chart and to come back so that you can sit down and talk to them about long-term management based on their underlying chronic type of incontinence. In order to determine the type of incontinence, first go back to the patient interview. What did the patient, what did the caregiver tell you about their primary problem? How did they answer the questions about leakage and ability to empty and awareness of the need to void? Then look at your physical assessment data. Does it back up your initial impression? What about the bladder chart? The bladder chart gives a lot of very critical information. So you've got data from your history, data from your physical, data from your bladder chart. You want to always make sure that you've ruled out voiding dysfunction, any kind of retention. You don't want to miss that. Once you determine the type of incontinence, you're ready to move ahead with your treatment program, but you want to revisit the patient's and the caregiver's goals for treatment. So this is where you have a discussion with them about potential treatment options. This is, what's going on based on what you've told me, what I found in your physical exam, what your bladder chart tells me. It looks like your primary problem is something we call overactive bladder or urge incontinence. Here are the treatment options. So you would explain the treatment options, and then you and the patient, you and the caregiver would jointly determine a treatment plan. Now, some patients will present with combination problems, so they might have stress and urge. Or they might have problems with urgency and frequency and leakage, but they also have problems with ineffective empty. How do you prioritize? You begin by treating any condition that could technically threaten the kidneys. So if you have a patient who has urinary retention, voiding dysfunction caused by an outlet obstruction, that's a high priority for treatment, because high pressure retention creates back pressure on the kidneys and the potential for renal damage. So that would always take priority. If you have both a problem with storage and a problem with emptying, such as an elderly patient who comes in with frequency and urgency and leakage, but assessment shows that they do not completely empty their bladder, that they have very high post-void residuals, again, you're going to focus first on the problem with emptying, because simply by improving their ability to empty, you are going to extend their voiding interval, you're going to reduce urgency, you're going to reduce frequency, and you will probably reduce the risk of leakage. If the patient has two types of incontinence, so two types of storage issues, for example, stress and urge, you're going to begin with the problem that is most difficult for the patient. For most individuals, urgency is more problematic than stress incontinence because urgency and urge incontinence typically involves higher volume leakage that is much more difficult to conceal and much more difficult to manage. However, it's again going to go back to what did that patient tell you? I'm going to take a couple of examples and walk through how you do data synthesis. So let's look first at a patient with stress incontinence. What would you hear from the history? They would tell you, I leak when I cough, I leak when I laugh, I leak when I'm at the gym and I'm doing anything that's high impact. So they're going to answer the question about leakage, yes. When you ask them what factors are associated with leakage, it's going to come back to activity. When you ask them, do you have intense urgency at the time you leak, they will say no. When you do the physical exam and you ask them to cough forcefully with a full bladder, almost always that will produce leakage, and it's going to be almost simultaneously with the cough. Also on physical exam, you will probably find weak pelvic floor muscles. They may have very limited contractility. They almost always have very limited endurance. Finally, you will find no indicators of retention. So they will say they feel like they empty, they have no trouble starting their stream, they void continuously until they finish. They have not had recurrent issues with urinary tract infection. Physical exam reveals no evidence of bladder distension. What about a patient with overactive bladder? How would their profile differ? Well, when they come in and you're talking to them about their primary problem, they're going to report frequency, urgency, possibly leakage on the way to the bathroom, and nocturia. On physical exam, what you're going to find is that if they leak with cough, it is a delayed leak, not an immediate leak. And when you screen for evidence of voiding dysfunction, again, it's going to come up negative. No feelings of incomplete emptying, no evidence of bladder distension, no recurrent UTIs. So you see that you always start with the history because almost always the history gives you the answer, the physical exam and the bladder chart confirm it. What if you had a patient with combination of stress and urge? What would you hear on history? Well, they would tell you yes and yes. Yes, I leak. Sometimes the leakage is associated with activity. Sometimes the leakage is associated with an intense urge to void. On bladder chart, you would see the same thing. So sometimes my bladder chart will reflect leakage with activity. I'm at the gym, I'm playing tennis, I'm swinging a golf club. And other times you will find leakage when I'm hurrying to the bathroom or when I report in my little comments column, had to go really badly, didn't quite make it. When you do my physical exam, you're probably going to find weak pelvic floor muscles, so limited contractility, limited endurance. My bladder chart will show frequency and urgency and leakage and low voided volumes because I'm voiding so often. And again, when you screen for evidence of voiding dysfunction and retention, that's going to come up negative. So those are just some examples. Now we're going to move into management options. There are some interventions that are required so commonly that we regard them as primary interventions. And then beyond that point, we're going to talk about interventions specific to each type of incontinence. So we'll talk big picture primary interventions, then interventions for stress incontinence, for overactive bladder urge incontinence, for incontinence associated with functional factors, for voiding dysfunction and retention, for neurogenic bladder, and for enuresis. In this class, we will focus on stress incontinence, urge incontinence, and functional incontinence. In the next recording, we will address voiding dysfunction, neurogenic bladder, and enuresis. And also in that class, we'll talk about indwelling catheters and absorptive products. So looking at primary interventions, first of all, fluid management. So we keep coming back to this, but it's so important that we're going to review it again. You want to look at the bladder chart. You want to identify any bladder irritants, any potential bladder irritants. You want to explain to the patient that high intake of caffeine, nicotine, carbonated drinks, artificial sweeteners, and for some people, citrus fluids may make their symptoms worse through mechanisms we do not totally understand. You want to explain to them that it may be helpful for them to reduce intake for 2 to 3 weeks, monitor the impact, and then decide whether they want to continue with the reduction or they want to go back to baseline. I was just at a conference and I was talking to a continence nurse who told me that she had a patient who drove several hours to get to her clinic because clinics weren't widely available. And that when she took her history and looked at her bladder chart, she immediately realized that she had very high intake of irritants, especially caffeine. She was drinking caffeine all day long, and she also had high intake of carbonation and artificial sweeteners. So in talking to her, she said, you know, one of the most important things for you to do is to cut way back on your caffeine, your carbonation, your artificial sweeteners, because I believe that that's contributing significantly to your symptoms. You have a lot of urgency, you have a lot of frequency, you're voiding or urinating very small amounts at a time, you're getting up a lot at night. Well, she said that the lady got very agitated and cut the visit short and left. And she didn't hear from her for a couple of months, and then she called, made another appointment, and came back. So she told her, she said, I was so mad at you for telling me to cut back on my caffeine and my carbonation, my artificial sweeteners, all my favorite drinks. She said, I called you every name in the book on my way home. And I'm like, why did I waste my time? Why did I go there? That was just really stupid, wasted my time, wasted my money. But she said, by the time I got home, I started thinking, well, you know, I did spend all that time and all that money to go to that center. Maybe I should at least do a trial like she suggested. And then I can tell her she was wrong. But she said, I did the trial and it made a phenomenal difference and I am so much better. And so I had to come tell you. And so the continence nurse said, well, you know, it's a long drive. You could have just called me. And she said, oh no. After all the things I called you on the way home, I had to come tell you face to face that it really did make a difference. So my point in telling you this story is this. Even though we have limited objective data, randomized controlled trial type data regarding the potential impact of irritants, there is substantial anecdotal data. Definitely enough anecdotal data to warrant a review of potential irritants and a discussion with the patient regarding the potential benefit of limiting intake of nicotine, caffeine, carbonation, artificial sweeteners, and possibly citrus fluids. We do want them to take enough fluid in to keep their urine relatively clear and relatively dilute. We used to really push people to take in at least 2 liters a day, but the emerging evidence is suggesting that probably 1,500 milliliters is enough for most adult women, and that reducing intake from 2,000, 2,500 milliliters down to 1,500 milliliters for a number of women, reduce their incontinent episodes. So instead of forcing them to increase fluids, let's look at 1,500 as a very good target. So that's basically 6 8-ounce glasses of fluid a day. If you have a patient who has a lot of problems with nocturia, you want to look at evening restriction. That's pretty obvious. People have been doing that for enuresis for years. It's kind of the same problem. Another primary management strategy is bowel management. So if that patient comes in with a colon full of stool, we're going to do a clean out. We're going to put them on a bowel program where we recommend fiber, we recommend fluid, we teach them the correct position for stool elimination so that we can make sure that the bowel is not contributing to the bladder dysfunction. And finally, for almost all patients, some modification and medications will be required. It requires me to look at the medications they're taking to determine which of those medications might be adversely affecting bladder function, and to collaborate with their primary care provider to either modify dose, to switch to a different medication, to look at timing, that kind of thing. Now let's talk specifically about stress incontinence. So most often this is in women, but sometimes it's in men with post-prostatectomy incontinence. Data indicate that weight loss is beneficial if your patient's obese. So if you look at that patient and he or she is significantly overweight, you want to counsel them about the potential benefits of weight loss and determine their level of interest in weight loss as an intervention. The primary therapy for stress incontinence is pelvic muscle exercises with or without biofeedback, or potentially an alternative exercise program, all of which we'll discuss. Scheduled voiding can be beneficial simply because women get very busy, they delay voiding, then they are walking around with a very full bladder, then they start coughing and they leak. If they get in the habit of voiding on a routine basis so that their bladder is not overly full, then there'll be lower risk to leak when they cough or laugh or sneeze or lift. You see that I put in italics EXMI, which is magnetic innervation therapy. We'll come back to that as extracorporeal magnetic innervation. And the use of serotonin inhibiting or serotonin related medication therapy. I put that in italics because at this point in time we have no data and it's not evidence-based therapy, but you'll still see it referenced in the literature sometimes, so we're going to discuss it briefly when we get to that point. Estrogen, on the other hand, widely recommended. Topical estrogen can make a big difference in rehydrating the urethral epithelium and reducing urethritis, reducing urgency and frequency. So topical estrogen can be beneficial in reducing urge symptoms. But for the patient with stress incontinence, topical estrogen also plumps up the urothelium and supports urethral coaptation, keeps the urethral walls sticky so that they can collapse against each other. So topical estrogen, an important tool when you're managing a patient with stress incontinence. I put estrogen or alternatives. What if you have a patient who cannot take topical estrogen, cannot use topical estrogen because of a history of breast cancer? There are increasing numbers of intravaginal gels that help to hydrate and lubricate the vaginal and the urethral epithelium that could be beneficial to the patient with stress incontinence who is unable to take estrogen. Pessary's clamps and inserts are used on a very limited basis. We will talk about when they're appropriate, and then we'll also talk about surgical interventions that can be beneficial for the patient with stress incontinence. I'm going to go in and remind you now, we mentioned this in a previous class, that when you look at the primary treatment strategies for patients with stress incontinence, it's going to come down to pelvic muscle exercises, topical estrogen for women with atrophic changes, and surgery. So let's start with pelvic muscle exercises. We've spent a lot of time talking about the impact of weak pelvic floor and sphincter muscles and the origin of stress incontinence. We've talked about the fact that when the periurethral sphincter muscles are weak and the pelvic floor muscles are weak, the patient's unable to mount significant urethral resistance, cannot provide enough urethral resistance to counteract the effects of increased bladder pressure. If we strengthen the muscles, if we improve endurance as well as contractility, then we improve that individual's ability to offset increased bladder pressure with increased urethral pressure. That's our goal. So pelvic muscle exercise is an important element of management for patients with mild to moderate stress incontinence, for patients with urge incontinence, and for patients with mixed stress and urge incontinence. I want to explain how pelvic muscle exercises can be a benefit to the patient with urge incontinence. I think it makes obvious sense why pelvic muscle exercises are beneficial for a patient with stress incontinence, because pelvic floor weakness is a contributing factor. Enhanced pelvic floor muscle strength obviously can be part of the solution. But what about the patient with overactive bladder and urge incontinence? How do pelvic muscle exercises help that patient? Well, interestingly, when you contract your pelvic floor muscles, there's a feedback loop to the bladder. And basically, pelvic muscle contraction sends a message to the bladder that says, relax, the door is closed. So if you are experiencing intense urgency, it means the bladder's getting ready to contract. But if you contract the pelvic floor, the message will go to the bladder that says relax. So bottom line, pelvic muscle exercises extremely beneficial for patients with stress incontinence, equally beneficial for patients with urge incontinence, and obviously then beneficial for patients with a mixture of stress and urge. Are there any contraindications? Yes, if you have a patient who has a very damaged or denervated sphincter, this is the patient who stands and leaks because they had an indwelling catheter for many, many months, or because they had repeated pelvic procedures that damaged the nerve pathways innervating the pelvic floor, pelvic muscle exercises will be ineffective. You cannot strengthen a severely damaged or denervated muscle. So patients with high volume leakage in response to minimal provocation are not good candidates. Attempting pelvic muscle exercises won't hurt them, but it won't help them, and it will be very frustrating. My analogy is if you have weak abdominal muscles simply because it's spring and you've been laying on the couch eating snacks and watching TV all winter, you can get off the couch, get on the floor, start doing exercises and strengthen your abdominal muscles, because there's nothing wrong with them. They're just weak from disuse. But if you have a neurologic lesion, if you have a spinal cord injury, you can't exercise the muscles in your legs because the nerves controlling those muscles do not work. Same thing in the pelvic floor. If you have a primarily damaged muscle, or if you have a muscle that is not innervated, exercises won't help. Exercises won't work. The other contraindication to pelvic muscle exercises is cognitive impairment. And that's obvious. I don't have to say anything else about that. So in assessing candidacy for pelvic muscle exercises, you want to determine, can that patient voluntarily contract those muscles? If that patient can voluntarily contract the muscles, even if they're very weak, that tells you the muscles are innervated and that that patient may benefit from an exercise program. If that patient cannot voluntarily contract, either because of cognitive impairment or because of denervation to the muscle, that patient's not a good candidate. And the mechanism of action for pelvic muscle exercises, obvious. It's a striated muscle. This is a voluntary skeletal muscle. So just as I can strengthen my biceps, my gluteals, my quadriceps, my abdominals, I can strengthen my pelvic floor. And if I do strengthen the pelvic floor muscles, I'm going to have increased contractility, so it's going to give me better squeeze, better ability to close the urethra, and it's going to give me better endurance so that I can hold the contraction and I can withstand leakage. So let's talk about how to instruct a patient in pelvic muscle exercises. The first step is to help the patient identify and isolate those muscles. So there was an interesting study done some time back. I wish I had the source. But they took a number of women who said, I know how to do those exercises and they don't help. And they did further assessment on those women. They determined, could they, in actuality, correctly do a pelvic muscle contraction? And what they found was that the majority of participants were contracting their abdominals, their quadriceps, or their gluteals, which means they had flat bellies, great legs, trim buns, and wet pants, because they were not contracting the pelvic floor. So they were contracting every muscle group in the region, but not the pelvic floor. So the first thing we have to do is help the patient find and isolate that group of muscles. It's a smaller muscle, so it's not easy. And it's not so visible, especially for women. Now, men can actually visualize, because if they correctly contract the pelvic floor, they'll get scrotal lift. So they can stand in front of a mirror and literally go 1 and 2 and 3. Women can't do that. So how do we help a female identify and isolate the pelvic floor muscle? One way is to do a digital exam. So put 1 finger or 2 fingers into the vaginal vault. Then instruct the patient to tighten and lift, just like we did on assessment. Tighten and lift. If she bears down, we correct her. No, not down and out, in and up. Okay, so try that again. And then when she contracts the right muscle group and she's doing that tighten and lift, even if it's very weak and even if she can't sustain it, she has identified the muscle. We're like, that's it. That's the muscle. That's the one we're working with. Different strategies and tips you can tell her. Contract as if you're trying not to pass gas. Contract as if you're trying to pick something up with your vaginal muscles. All of the things that we talked about when we were talking about pelvic exam on assessment. So first of all, help her find that muscle. And then that's the muscle you're concentrating on. And remember, every time you do a contraction, you're trying to focus on in and up, okay? Tighten and lift. That is a very effective way to teach pelvic muscle exercises. Studies indicate that the majority of women are able to learn how to do appropriate pelvic floor muscle contractions with this technique. Finger in the vagina, feedback to the patient. Now, for a time, a number of clinicians used urinary stream interruption as a way to help women identify the right muscle group. And they did that based on the fact that it is the pelvic floor muscles that we use if we're trying to interrupt the urinary stream. However, that technique has fallen out of favor, and that's why it's in italics, and this is why. Some women started routinely trying to interrupt their urinary stream, and that led to mixed messages to the brain. Here's the bladder trying to contract and empty, and then they're contracting the pelvic floor to stop urinary flow and to interrupt the bladder contraction, and then they're opening up and then they're stopping. And that can create a dysfunctional voiding state. So if you ever use this to help patients identify the right muscle group, you want to caution them to do this no more than 1 time weekly. Do not do this on a routine basis. But I will tell you this, if you can interrupt your urinary stream, especially when your bladder is relatively full, you do have good pelvic floor muscles. The third approach is biofeedback. Biofeedback involves use of intravaginal or intraanal probes or pelvic floor sensors. And they give you feedback, visual feedback on a screen as to when you are contracting the pelvic floor. So if you look at this, you can see that here the patient was contracting, and here they got a little bit of a contraction, and then a partial contraction, and then a strong contraction. But you can see that even though they have pretty good contractility, they don't have very good endurance. That's very helpful feedback for the patient. So I can literally see, okay, I'm contracting the right muscle, but I'm not doing a very good job of holding it. That tells me try again to contract it. Okay, relax it. So biofeedback is simply giving me information about what I'm doing. It's giving me information in a visual format. Whereas if you put 1 to 2 fingers in my vagina and gave me verbal feedback, it's a different approach. Both give me feedback. Yes, that's the muscle verbally, or yes, that's the muscle visually. So biofeedback is a third approach to making sure that that patient is contracting the right muscle and that she or he knows that they're contracting the right muscle group. And so that they have information about how strong their contraction is and how long they're holding it. This is the critical first step. You cannot put me on an exercise program until I can consistently identify and isolate the correct muscle. Now, some clinicians work very hard on making sure that the patient is not also contracting the abdominals, the gluteals, or the quadriceps. So that's what they mean when they say isolate, identify and isolate. You want them to contract the pelvic floor. You want them to try to avoid contraction of other muscle groups. Other clinicians will say, I'm not as worried about that. I'm mainly concerned that they know where their pelvic floor muscles are, that they can contract those muscles. So identify, absolutely. Isolate, some clinicians work harder on that than others. And we don't have enough data at this point to know how critical it is that you emphasize avoidance of contraction of other muscle groups. Okay, so you've worked really hard with this patient, and she or he can now consistently contract the pelvic floor. It might be weak, it might not be sustained very long at all, but the point is when you say tighten and lift, they can consistently tighten and lift. At this point, you're ready to move to the next step. And the next step is setting them up on an exercise program. Now remember that the pelvic floor includes both fast twitch and slow twitch fibers. Fast twitch 1/3, those are the ones that allow you to rapidly increase urethral resistance to try to prevent leakage. Slow twitch fibers provide sustained resistance, so they provide you continence over time. There's a couple of ways to do this. Some clinicians use 2 different types of exercises, so they'll tell patients, okay, I want you to do 5 quick flicks, and I want you to do 10 sustained contractions. So what does a quick flick look like? It looks like this. I want you to try to do a quick flick right now. So a quick flick is tighten just as hard as you can and immediately relax. Wait for 10 seconds. You want that muscle to fully relax. Contract as hard as you can. Relax. Wait for 10 seconds. Contract. Relax. Okay, so it should look just like this. It should look like a spike. You always give them at least 10 seconds relaxation time. Okay? In contrast, the contract and hold, a sustained contraction, you want them to contract and you want them to focus on holding for as long as they can. So if right now, if you do a sustained contraction, you focus not so much on intensity, you focus much more on endurance. So contract, hold it, hold it, hold it, hold it. Okay, you're trying to help them maintain that contraction. That's contracting, that's exercising your slow twitch fibers. So quick flicks, exercise your fast twitch, contract and hold, exercises slow twitch. The other approach that some clinicians use is to just tell the patient, I want you to contract as hard as you can, and I want you to hold it as long as you can. And their rationale is, when I contract as hard as I can, I'm engaging both my slow twitch and my fast twitch. When I'm holding it as long as I can, I'm relying on my slow twitch. Either approach seems to work. In a recent review of studies on efficacy, effectiveness of different types of pelvic floor muscle exercise programs, and this was reported in the chapter on stress incontinence in your core curriculum, the conclusion was that at this point in time, all approaches seem to work. That it does not seem to matter which specific approach you use as long as the patient is isolating and contracting the right muscle group and doing the exercises repetitively and consistently. So at this point, our best evidence is that one approach is not better than another approach. So what you want to do is you want to create an individualized program based on this patient's current level of function. So if I'm your patient and I have pretty good contractility, so when you tell me contract your pelvic floor, you can definitely feel me contract. The problem is my endurance is minimal. So I can contract, but I cannot hold. Then you're going to focus primarily on endurance, but you're probably going to give me some quick flicks in there because I'm good at that and it makes me feel good. So you might say to me, okay, Dorothy, we want to maintain your ability to contract your fast twitch fibers, but we want to improve your ability to contract your slow twitch. We want to improve your endurance. So I'm going to start you on 3 sets of 15 exercises a day, 15 repetitions a day. During each exercise set, I want you to do 5 quick flicks. Contract, relax. Wait, contract, relax. Wait, contract, relax. Okay, I want you to do 5 of those. I want you to do 10 contract and hold. Relax, contract and hold. Relax. Always 10 seconds relaxation time. And you're going to tell me, I know these are going to be harder for you. At this point, your endurance is between 2 and 3 seconds. So our initial goal is going to be 5 seconds. You might not meet it initially, but that's our first goal. Once you consistently are able to hold that contraction for 5 seconds, we'll raise the bar a little bit. We'll go to 7 or 8 seconds. But right now, every time you do a contract and hold, you're shooting for 5 seconds. So get out your watch or sit in front of a clock and time your ability to hold that contraction. And try not to be too discouraged if you can't hold it for 5 seconds initially. That's why you're doing this exercise program. All exercise programs require time to make a difference, and it's a building process. So we're starting here. We're going to come to this level, then we'll go to the next level, and within a few months you'll be surprised at what you can do. So you always individualize the program based on where I am. One other thing, most clinicians find that the easiest position in which to do pelvic muscle exercises if your muscles are very weak is lying down, because you don't have any gravitational force. So if you have a patient with very weak muscles, you might start them in the supine position. And you might say, I want you to do a set of 15 in the morning before you get out of bed. Is there any place you can lie down middle of the day? Well, if I work, maybe there's no good place to lie down. So I might have to start with 2 groups of 15, one in the morning, one at night. Once I get a little bit stronger, now you can have me do 1 set sitting up. So maybe 2 sets lying down, 1 set sitting up. As I get even stronger, I can do 1 set lying down, 1 set sitting up, and 1 set standing. So then you try to plug it into my schedule. Okay, let's see when you're going to do this. Don't just send me home with anything vague. My prescription has to be very specific. So you're going to do 15 reps. For the next week, you're going to do 15 reps twice a day. 5 quick flicks, 10 contract and holds. Both sets will be done in the supine position. You're going to do 1 set in the morning after you hit the snooze alarm while you're still in bed. You're going to do the second set in the evening, either lying on the couch or when you first go to bed before you go to sleep. Once you add the set sitting, so midday I'm going to do a set while I'm sitting at my desk. Okay, how am I going to do that? I'm going to do that at work, sitting at my desk. Can I do it at lunchtime? Can I isolate myself at lunchtime so I can focus on doing these exercises? Once you add a standing set, maybe my morning set should be done in the shower, standing. And then my midday set should be done at my desk, sitting. And then my evening set can be done lying. You see how specific you want to be so that I know exactly when I'm going to get it done or it won't get done. So very specific recommendations in terms of fast twitch versus slow twitch, or you may go with contract and hold. How many repetitions, in what position, what is my goal for endurance? Now, some additional things that have been used and are being used for pelvic muscle exercise instruction. There are some weighted vaginal cones that are available. They help by providing sensory biofeedback. So you put one into the vaginal vault, the heaviest one that you can hold. And for most women beginning a pelvic muscle exercise program, it's usually weight number 1. Now, you would not introduce these until your patient has at least a 2 to 3 level on the scale of 0 to 5. Their pelvic muscles need to be at least at 2 to 3 to be able to hold in the lightest weight. So you put the weight in just like a tampon. Then they're supposed to be up and engaged in just light activity, and their goal is to hold that in for a period of time, 10 to 15 minutes. It's much harder than you think because that weight wants to come out. Now, they think that use of the weights works by 2 different mechanisms. First, the weight on the pelvic floor increases reflex activity in the pelvic floor. And secondly, it gives me sensory biofeedback. So if the weight starts to slip out of position, I can feel it. That reminds me, tighten up. If I inadvertently bear down, if I push down and out instead of tightening and pulling up and in, that weight's going to fly out and hit me on the big toe. And that's another kind of sensory biofeedback. So do the weights do anything over and above the pelvic muscle exercise, or do they primarily serve as a form of biofeedback? We think they primarily serve as a form of biofeedback. We don't have any data to date that indicates that they're any more effective than a plain pelvic muscle exercise program. So whether or not you use them is based on that patient's need for some kind of biofeedback and what's available to her. We've talked about biofeedback, two major forms. There's pressure-sensitive biofeedback and EMG biofeedback. Pressure-sensitive, you have an intravaginal or intraanal probe with a sleeve that's filled with air or water, and so when the muscles contract, they create pressure around that sleeve, and that pressure is transmitted to the screen, so you literally see the effects of your muscle contraction. EMG biofeedback, you have a probe with EMG sensors, or you have pelvic floor sensors that you can just attach to the pelvic floor. And it's going to pick up on pelvic floor muscle activity. So when you contract, again, it's transmitted to the screen. When you relax, you can see it flatten out. We've already talked about the potential benefits of biofeedback. Biofeedback, however, does add cost. So for some patients, it makes a huge difference, and it's absolutely worth that cost. Other patients are perfectly capable of learning pelvic muscle exercises and doing the program without biofeedback. And in that case, it would be a waste of healthcare dollars. So you have to match therapies to the patient. One thing you should know about biofeedback, it can be used in a variety of ways. There are some units that are used only in the clinic, and so the patient might have biofeedback one time simply to learn and reinforce the correct technique. Other patients will have biofeedback every time they come back to the clinic, again as a method of assessment and reinforcement. And finally, there are some home biofeedback units, so you can send the patient home with a unit that coaches them through their exercise regimen, and that also keeps a record, so it enforces or reinforces compliance with the exercise regimen. That's probably what I would need. You would need to send me home with something that told on me and said she didn't do her exercises. That would get me on board. Absolutely critical to teach the NAC. What is that? The NAC is nothing more than using your pelvic muscles before activities that increase abdominal pressure. So I'm about to cough. When I'm taking in my deep breath, before I cough, I should tighten my pelvic floor. I'm about to lift a heavy object, a child, a patient, contract. I'm about to sneeze while I'm going, I should be contracting my pelvic floor. So it's nothing more than using your pelvic floor muscles in everyday life to improve pelvic muscle function. You can also tell sexually active women, contract your pelvic floor during sex. That's great exercise. So you can say to your partner, did you feel that? And if he says, feel what? You're like, never mind. If he's like, yes, that was really impressive, it's like, okay, I've been exercising. And then there are some alternative programs. So some women have just a very, very hard time isolating the pelvic floor muscles. So they may benefit from programs that begin with abduction and adduction of the thigh muscles against resistance. You can do that with the Thigh Master at the gym. So you, let's see if I can get this right, adduct against resistance, abduct against resistance. You can also take an exercise ball and exercise bands to adduct against resistance, abduct against resistance. Why does this help? It helps because the muscles that control the thigh muscles insert on the pelvic floor. So when you abduct and adduct against resistance, it also contracts the pelvic floor. Notice when you're on the thigh master at the gym, you can feel it in your pelvic floor. So for younger women, middle-aged women who go to the gym, they can get on the thigh master and kind of get better thighs and drier pants all at the same time. That's a pretty good deal. Another thing you can do the standing plie, that ballet maneuver. So I'm going to move over here so you know the ballet maneuver where you're doing like this. You can do your arms if you wish. But basically you put the heels of your feet together and then you're doing a partial squat and hold it. And you can feel the tension in your pelvic floor. So when you're drying your hair, you can be doing standing plies. Women love to multitask, so there's just another multitasking option. The point is there's many different ways to help people get from point A to point B. So you want to work with your patient. You want your patient to work with her pelvic floor muscles, or in the case of a post-prostatectomy patient, his pelvic floor muscles. I had one patient who told me he leaked when he swung his golf club. I'm like, okay, before you swing your club, I want you to contract your pelvic floor muscles. I'm going to put you on this program, and then I want you to use these muscles every day in real life. So he came back and he said, it really helped, and I taught my girlfriend, and it's helping her too. So see, pelvic floor muscle exercises are pretty much good for almost everyone. Okay, so key points summarizing pelvic floor muscle exercises. We spend a lot of time on this because it's a primary management strategy for women with stress incontinence, men with post-prostatectomy incontinence, patients with overactive bladder and urge incontinence, and individuals with mixed stress and urge. And remember, those patients account for almost 80 to 90% of individuals with incontinence issues or voiding dysfunction. A very important intervention. You need to know how to teach people pelvic muscle exercises. So you start with yourself. Make sure you're doing your exercises correctly. Make sure you know the difference between quick flick and contract and hold, and try some of these alternatives as well. So summarizing, beneficial for stress, urge, and mixed. What have you got to do? You've got to help the patient identify the muscle. You've got to help the patient strengthen the muscle. You want them to learn how to use the muscle in everyday activities. And you also want to make sure that they can relax the muscle. Patients who cannot relax their pelvic floor muscles, their muscles are chronically fatigued, so if you can't relax it, you can't contract it as effectively as you should. And a chronically contracted muscle can contribute to pelvic floor pain, pain with intercourse, constipation, and difficulty emptying. So you want to make sure I can contract, you want to make sure I can hold, you want to make sure I can relax. And you want to make sure that I know when to do each of those things. When should I contract? When should I relax? Okay, what else can I do? Well, scheduled voiding, we already mentioned that just telling women, make sure you empty your bladder about every 3 hours so you're never dealing with an overly full bladder. If your bladder's overly full, you're much higher risk for leakage when you cough or laugh or sneeze. What about electrical stimulation? Electrical stimulation has been used in the past to treat stress incontinence. You take intravaginal or intraanal probes, and it's low voltage stimulation, so you're not hopping around the countryside. But what happens with electrical stimulation is it causes depolarization of the nerves and the muscles in the pelvic floor, which stimulates muscle contraction. However, we have very limited data regarding effectiveness, and as solo therapy, it seems to be very ineffective. So electrical stimulation might be used by some physical therapists as a component of a pelvic muscle rehab program, but it is never standalone therapy, and it's not what we're going to focus on. So I want you to focus on strategies you can use with every patient with very simple equipment. What about extracorporeal magnetic innervation? Now, we've already said that that's in italics because we have no evidence proving its benefit. It's kind of too bad because it's a very simple, easy therapy. You come in, you sit fully clothed in this big chair, looks like a kind of strange armchair. There's a great big magnet in the seat. The magnet is controlled by electrical current. You can program a little card so that you create a therapy program for this patient. Okay, stick it in, turn the system on, and then the magnet depolarizes, or the magnet is switched on. That depolarizes the nerves and muscles and triggers pelvic floor muscle contraction. So for a while, this was very popular. But if you do not cross that patient over to active therapy, to active pelvic muscle contractions, then they're going to lose any benefit that they gain. And so at this point, this therapy is not recommended. We have no evidence regarding any sustained benefits from that. I don't think you'll see it on the certification exam. You definitely will not see it on our exam. So don't spend time on it. Just in the back of your head, put doesn't work, too bad. The NAC we've already talked about. What about medications for stress incontinence? There's only 2 medications that can potentially be of benefit that we know about now. Both of them are off-label use. So what about pseudoephedrine? It's a sympathomimetic. We know that sympathetic stimulation of the bladder neck tightens the bladder neck. So theoretically, pseudoephedrine could reduce the incidence and severity of stress incontinence. However, you have to think about the times that women are highest risk for stress incontinence, and it's during activity. And the one time you do not want to give someone a sympathomimetic is during exercise, during sustained activity, because what do those medications do? They increase heart rate, they increase blood pressure. So pseudoephedrine very rarely used for management of stress incontinence, and if anyone uses it for that, it's very much off-label. What about duloxetine, Cymbalta? It's a selective serotonin norepinephrine selective reuptake inhibitor. And it has been shown to significantly reduce the incidence and the severity of stress incontinence. However, it is not approved for that. It's not FDA approved for that because in the studies that they did looking at Cymbalta for stress incontinence, they failed to track the incidence of suicidal thoughts. And we know that these drugs, they're used as antidepressants, and we know that increased suicidal ideation and suicide attempts is one potential side effect. So because they did not have data on the incidence of suicidal ideation and suicide attempts, they could not get clearance for use of duloxetine in the management of stress incontinence. So it would be off-label use. It's not typically frontline therapy, but if you have a patient who has both clinical depression and stress incontinence, use of a serotonin norepinephrine selective reuptake inhibitor, SNSRI, such as duloxetine, would be appropriate. What about topical estrogen? Absolutely. If you have a postmenopausal female who has evidence of urogenital atrophy, so atrophic vaginitis, atrophic urethritis, estrogen, topical estrogen can be of significant benefit because it is going to rehydrate and replump the urethral tissues. Is going to improve urethral coaptation as well as reducing urethral irritability and bladder irritability. So very definite benefits. Reduces atrophic changes, reduces bladder irritability, reduces the incidence of UTIs in older women. So benefits very well defined. Topical recommended as opposed to systemic because systemic has significant adverse effects. Topical does not. So you get the same benefits from topical estrogen, but you don't get the adverse effects. So maximum benefit, minimum risk. There's multiple forms. There are creams, there's tablets, there's a sustained release ring. You see that on the slide. Most patients who have significant atrophic changes will require a loading dose, so that typically means a cream every day for 2 or 3 weeks. And then you can switch to maintenance therapy, which would be cream or tablet twice a week, or the sustained release ring replaced every 90 days. What about pessaries? A lot of people think, oh my gosh, they're so old-fashioned. Are they still out there? They're still out there. They're alive and well and making a difference for women who need them. So you may or may not be skilled in insertion and fit and maintenance of pessaries. If you're an advanced practice nurse or a continence nurse working in a continence center, working with a urogynecologist, yes, you will probably learn how to fit pessaries, how to maintain pessaries. If you are not, you need to know who in your area does pessary work, who fits pessaries, who evaluates patients for pessaries so that you can make appropriate referrals. What do they do? Why are pessaries potentially a benefit for a patient with stress incontinence? Well, they're all intravaginal devices, so when you put them into the vaginal vault, they support the anterior vaginal wall, and they provide support right at the bladder neck. They can provide some degree of urethral compression, which helps reduce the risk of leakage, and they are very beneficial in opposing pelvic organ prolapse. So if you put a pessary in, and here you see a pessary placed, it's in the proximal vagina, is providing support right at the bladder neck. So by providing support at the bladder neck, it helps to hold the urethra and the urethral sphincter in position so that you get optimal urethral sphincter function. Remember, if the sphincter am in position, it's much easier for me to do a circumferential squeeze and to effectively close the urethra. If I'm stretched out of position, it's very hard for me to do that. So simply by providing support right at the bladder neck, a pessary can promote continence. Again, it can also provide some degree of urethral compression that helps oppose leakage. Critical after a pessary is placed to make sure that the patient can void effectively, that they do not have high PVRs. So that's one of the things we always check after we place a pessary. And you can certainly see that an intravaginal device can be used to reduce the risk of prolapse. So women who have significant stress incontinence, one of the things we can consider in their management is use of a pessary, possibly short-term until they're able to gain sufficient pelvic muscle strength to eliminate leakage. For women who are scheduled for surgery, but it's going to be several months, sometimes a pessary is used short-term for management of their incontinence. Most commonly, pessaries are used for women who have a combination of incontinence and prolapse, or women who have prolapse and impaired emptying. So prolapse is a big reason for use of pessaries. So prolapse with incontinence, prolapse with retention, but pessaries can also be used for incontinence alone. I was with a nurse practitioner who fitted a patient for a pessary. This patient had significant sphincter denervation. So pelvic muscle exercises were not going to work for this patient. And she was a very poor candidate for any further surgery because of an anaphylactic response to anesthesia. So she has a denervated sphincter. She's leaking whenever she stands up. And she's in her late 60s, and she's a very active woman. So she's like, I'm so tired of having to wear bulky, absorptive products all the time. It makes me feel like an infant, and my skin's always irritated, and I hate it. But I can't have surgery. Exercises won't work. What else can I do? So we said, well, one thing you could do is a pessary. We could fit a pessary, and we could fit one that holds everything in position and also creates a little bit of compressive force against the urethra, and then we'll have to make sure you can urinate, but it might keep you either totally dry or at least it could significantly reduce the volume of your leakage. She's like, absolutely. So the nurse practitioner, fitted her for a pessary. She made sure the tissues were well estrogenized and healthy, and that she could tolerate a pessary. She had well estrogenized tissue. She had been using topical estrogen. So she estimated the appropriate size of the pessary just by doing an intravaginal exam. She put the pessary in. She said, is that uncomfortable? No. She said, bear down, let me see if it moves out of position. It didn't. She's like, okay, I want you to stand up and do those same things. And when the patient stood up, she started crying. And so the nurse practitioner, of course, thought she was in pain. She's like, lie down, I'll get it right out. She's like, no, I'm crying because this is the first time, and I can't tell you how many months that I stood up and urine did not run down my leg. No way you're taking this pessary out. So I just want you to know that even though they have the people think of them as being very old-fashioned, actually there's still many people who can benefit from an appropriately fitted pessary. So I don't want you to be afraid of them. I want you to recognize them as a very beneficial tool for selected women. Doesn't matter if you don't know how to fit them. There are nurse practitioners and continence nurses who can fit them. There are urogynecologists who can fit them. So if you don't know how to do it, find somebody in your area who can, so you know where to send people. Okay, that's my commercial for pessaries. I'll get off my little soapbox. So we talked about they have to be fitted correctly. You have to teach the patient either how to remove them, clean them, and replace them, or they have to come back on a routine basis for a clinician to remove, clean, and replace them. They can be extremely helpful. What about penile clamps? So you see the slide on top. Does that not look just barbaric? It looks barbaric to me. But I have had a number of patients who have come in using those clamps and who are very happy with them. So this one on top is known as a Cunningham clamp. It's lined with foam. It literally is a clamp. How do they work? They compress the penile tissue, they compress the urethra, and they stop leakage. Obviously, they should be used only in men who have intact sensation, who are cognitively intact, because they have to be able to protect their tissue. So they have to recognize ischemic discomfort, and they have to know the importance of routinely releasing the clamp. So it should be released on a routine basis every 2 to 3 hours. Also, these clamps are not appropriate for men who have some combination of stress incontinence and overactive bladder urge incontinence, because you don't want the bladder contracting against a closed urethra. So it's appropriate only for a male with intact sensation, intact cognition, and stress incontinence only. But they can be safely used in that situation. So I just want you to be aware of them. And for some men, they'd much rather use a clamp than use any kind of absorptive product. Men tend to hate absorptive products. They've never been wet, and they don't want to start now. For women, there are urethral inserts. There's actually only one on the market. It's Film Soft urethral insert. And what it is, it looks like a very soft, intermittent catheter. You place it into the bladder, and then this little mineral oil-filled balloon is inflated. It literally blocks the bladder neck, so keeps urine from going out. So it's literally a plug. It's like a urethral plug. It's one-time use. So some women find it very helpful. They'll use this when, say, they're going to the gym, or they're going to play tennis, or they're going out on something important and they don't want to have to wear a pad, but they want to be sure they stay dry. And then they just remove it to void. You have to use a new one every time. There has been a fairly significant incidence of urethral discomfort, some problems with bleeding, not enough to require the device to be removed from the market, but certainly something to caution patients about if they're interested in using it. And could be used only by a patient who had enough dexterity, enough confidence, and enough cognition to essentially do a self-catheterization, because putting this in is like self-catheterizing. Then the last thing I wanted to talk about as a therapy for stress incontinence is surgery. So the two primary therapies are on opposite ends of the invasive scale. You've got pelvic muscle exercises and topical estrogen on one end, and then you have surgery on the other end. The most commonly performed procedure are your tension-free slings. So this is your tension-free vaginal tape procedure, tension-free obturator tape procedure, and there's others coming out as well, but those are by far the two most common. Now, in the past, what they did was a retropubic suspension procedure, so they would make an open incision, and then they would take either fascia or some kind of synthetic material, loop it around the bladder neck, and then attach it to the symphysis pubis. So they literally were lifting and securing the bladder. So that was commonly called a bladder tack. But it was an open procedure, required hospital time. Patients typically had significant problems with retention for the first few weeks post-op. So just the morbidity, the cost, all of that kind of stuff was significant. With the tension-free vaginal tape, tension-free obturator tape procedure, they have these little kits, so they make small incisions either intravaginally or through the over the obturator canal. And then they feed a strip of synthetic material right beneath the urethra, just under the posterior urethral wall. And then the tape is brought out and clipped and secured, but there's no tension on the tape. So if this is the urethra, the tape comes under the urethra and then is secured to the pelvic side walls or wherever, but there's no compressive force placed against the urethra. So how does it work? Well, when you put this in, it fills with collagen, and that collagen acts to stabilize the urethra and hold it in place. So it's like a very beneficial scarf. Locks the urethra in place, so it improves sphincter function. So tension-free vaginal tape, TVT, tension-free obturator tape, TOT, are now the most commonly used procedures worldwide. Now, long-term outcomes have been generally good, so 80 to 90% continence long-term, relatively low complication rates, done as a day-stay procedure, and generally very well tolerated. So that's certainly another option for a woman who has incontinence related to weak pelvic floor muscles that allow the sphincter to drop out of position. Now, what about a patient who has severe stress incontinence because they have a denervated or damaged sphincter? For that patient, doing a tension-free tape procedure probably would not give them continence, because you need more than stabilization. If your urethra does not close, if your sphincter does not work, simply holding it in place is usually not enough. So for patients who have severe stress incontinence due to sphincter damage or sphincter denervation, there are 3 procedures that actually work to increase urethral resistance to help close the urethra. The first is a compressive sling. So here you see a loop of fascia or rectus muscle or synthetic material wrapped around the urethra, the bladder neck, brought forward either to the symphysis or to the rectus, and secured with enough tension to help compress the urethra, to bring the back wall of the urethra toward the front wall of the urethra in order to prevent leakage. Now, I was at a conference and they were talking about complications of these compressive slings versus benefits of these compressive slings, and they were saying it all depends on getting the level of tension right. So you need enough tension to close the urethra, but you don't want so much tension that you obstruct the urethra. So you want it closed at rest, but when the bladder contracts, you want it to be able to open. Closed at rest, but able to open. If you don't close it at rest, you have continued leakage. If it's closed so tightly that the bladder can't open it effectively, then you're going to have a whole new set of symptoms. You're going to have urgency and frequency and obstructed voiding. So the point at this conference was, if you're looking to have one of these sling procedures done for severe stress incontinence, you need a surgeon who does them all the time and knows how to get that tension right. All I want you to know is that compressive slings are one option for a patient with severe stress incontinence due to a damaged or denervated sphincter. What are the other 2 options? Artificial sphincter. So here's a diagram of the artificial sphincter. It's a cuff that's wrapped around the urethra. Then there is a reservoir that's in the abdominal or pelvic cavity. And then there's a pump mechanism that's placed either in the scrotal sac or in the labia. Now, at rest, the cuff is inflated, and when the cuff is inflated, it closes the urethra. When I'm ready to void or to catheterize, I need to activate the pump to take the fluid out of the cuff and to put it back into the reservoir. That allows me to void or catheterize. Over 2 minutes, the cuff passively refills and the urethra again closes. This is a very complex procedure. It's generally effective for both men and women, but it involves placement of a cuff, a reservoir, and a pump, and the connecting tubing. So infection's a potential issue, rejection's a potential issue, and so it's only done in very select centers. The third option is periurethral bulking, where you go up through a cystoscope and you literally inject the urethral walls with a filler product. It can be collagen or a collagen synthetic mix. So I heard a surgeon say we use some of the same things that the Hollywood stars use to plump up their lips, only we're plumping up the urethra. And you can see that once you plump the urethral walls, you significantly increase urethral resistance. The problem is it takes more than one injection. The materials used to plump the urethral walls gradually break down, so you usually have to come back and have it done again. Nonetheless, it is an option. What do you need to focus on in terms of surgical options for management of stress incontinence? You need to know that for women with stress incontinence caused by pelvic floor weakness that the mid-urethral tension-free slings are the most commonly performed procedure. That they work by stabilizing the urethra, stabilizing the sphincter, holding it in place so that it works more effectively. You should know that for women and men with severe stress incontinence caused by a damaged or denervated sphincter, they're going to require a surgical procedure that literally increases urethral resistance. That there are 3 types of procedures. One's a compressive sling, one's an artificial sphincter, and one's a bulking procedure. That's what you need to know. Okay, we're leaving the land of stress incontinence, and we're going to start talking about management of patients with overactive bladder and urge incontinence, another very common phenomenon, but fewer treatment options, you'll be glad to know probably at this point. So the first thing you want to think about is, well, what's going on with this bladder? It is a hyperactive bladder. It overreacts to small amounts of urine in the bladder. It's constantly sending messages that it's full, it's full, it's full. So the first thing we want to do is use lifestyle interventions just to calm the bladder down. It's all upset all the time, so we want to calm it down. Weight loss can be beneficial because you take some of the pressure off the bladder, so think about counseling your obese patients regarding the potentially beneficial effects of weight loss, see if they're interested in that. We've already talked about how important it can be to reduce irritants. Worth a 2 to 3 week trial of reduction, caffeine, artificial sweeteners, carbonation, alcohol, possibly citrus fluids, to see does it make a difference. For many patients, it makes a phenomenal difference. I always say that a very simple diagnostic test is to just drink a Diet Coke and see what happens. Monitor the effects of a Diet Coke on your bladder function because it has everything. It's got caffeine, and it's got carbonation, it's got artificial sweeteners. So you're not asking them to give these things up forever. You're suggesting a 2 to 3 week trial of reduction to see if it makes a difference. You definitely want to do a bowel clean out if this patient's constipated and get them on an effective bowel program so that the rectosigmoid stays empty. If the rectosigmoid is full, that acts as an irritant to the bladder because it does not have room to expand. And finally, topical estrogen to correct urethritis, because when you have atrophic changes in the urethra, it becomes very dry, inflamed, and irritable. Also, you want to implement environmental modifications to facilitate toileting. So can you change my clothing style so it's easier for me to get my clothes out of the way? Can you suggest a bedside commode for use at night or a urinal for use at night? What can you do to make it easier for me to get to the bathroom in time? The primary behavioral intervention for a patient with overactive bladder and urge incontinence is known as bladder retraining. And the whole goal here is to restore normal voiding patterns or close to normal voiding patterns. Now, in terms of indications, the patient has to be motivated. It's not an easy program, and they have to be cognitively intact. It's a simple program, but it's hard because it makes you do something that is counterintuitive, and we'll talk about that in just a minute. So first you want to teach me mind over bladder, bladder control strategies. If you ask people who have overactive bladder, urge incontinence, what they do when they get that strong urge to void, this is what you're going to hear. They're going to say things like, I'll just be sitting at my desk and I'll be working on something, and all of a sudden I have to go, and I have to go right then, and I know I have to go right then. Then I say to them, and what do you do? Well, I jump up. I jump up right away and I hurry off to the bathroom. Okay? That's exactly what I want you not to do. Because when you jump up, you just increased abdominal pressure, which is like popping the bladder, punching the bladder. And if you have a bladder that's already on edge, that can push it over. So I want you not to jump up. Furthermore, when you jump up and you run down the hall, now you're bouncing that twitchy bladder, and if you don't push it into a bladder contraction, it's a miracle. So even though everything in your body is saying go, 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 I want you to stop. Okay? I want you to freeze. Either stand still or sit down. Secondly, I want you to squeeze. So I want you to do 5 quick flicks. Contract, relax. Contract, relax. Contract, relax. And do 2 more. What does that do? A couple of things. First, when you contract the pelvic floor, closes the urethra, reduces the risk of leakage. Secondly, when you contract the pelvic floor, sends that feedback message to the bladder, stand down. Do not contract. The door is closed. Also, I think it helps distract people so that they're focused more on doing their pelvic muscle exercises than they are on the bladder, and that's beneficial as well. The third thing I want you to do is deep breathe. Deep breathing has a calming effect on physiologic functions of the body. So we know deep breathing can reduce heart rate, reduce blood pressure. It can also interrupt a bladder contraction. So stand still or sit down, 5 quick flicks, and then focus on deep breathing. Then use the quick flicks and the deep breathing alternately until that intense urgency goes away. Now I want you to try this yourself because it's counterintuitive. It feels like you need to get to the bathroom as fast as possible. So when you have intense urgency, I want you to stand still, freeze. I want you to do quick flicks, squeeze, and then I want you to breathe. Because if you've done it yourself and you know it works, you'll be much more convincing when you talk to your patients. Once my urgency is controlled, I can walk to the bathroom. If my urgency recurs, I need to stand still, do my quick flicks, do my deep breathing, then continue to walk. Okay, step number 1, teach me bladder control strategies, mind over bladder. Okay? Secondly, you want me to start extending my voiding interval. So let's say that right now I'm voiding every hour to hour and a half. And I really want to get to at least 3 hours. Okay, how am I going to get there? Well, first I have to be able to control urgency, so we just did step number 1. Step number 2, you're going to put me on a voiding schedule. And you're going to tell me to void on schedule. You're going to tell me to void by the clock, not by the urge. If I don't have the urge and it's time to void, void anyway. If I had the urge and it's not time to void, use freeze, squeeze, breathe to control the urge. Because I've got to retrain my bladder. I've got to teach my bladder that I'm in control, not him or her. So I'm going to take my bladder to the bathroom on schedule. And if it says I don't have to go, I'm going to say go anyway. And when it says I got to go right now, I'm going to say wait. You're putting the person back in control. So your initial schedule is based on their current voiding frequency. So you have them do a bladder chart. Let's say that, I think I said I was voiding every hour to hour and a half. Okay, so sometimes I'm going an hour and a half, so we're going to start with an hour and a half. So you're going to say, okay, you're going to void every hour and a half. So we're going to start it when you first get up in the morning. What time do you get up? 6 o'clock. Okay, 6 o'clock you're going to void, 7:30 you're going to void, 9 o'clock you're going to void, 10:30 you're going to void, 12 noon you're going to void. So I'm going to give you a schedule. And you're going to follow that schedule. You're going to use freeze, squeeze, breathe to control episodes of urgency so that you can make it to the next assigned voiding time. Okay, let's say that I've got my urgency under control. Let's say it's 10:10. I'm not supposed to void again until 10:30. I just had really severe urgency. Now I did the freeze, squeeze, breathe. I have my urgency pretty much under control. Should I sit here and watch my watch and say, wow, 20 minutes. Wow, that's a long time. I don't know if I can make 20 minutes. I'll try, but oh my gosh, 20 minutes. No, I'll never make it. I need to distract myself. Think what you do when you have to go to the bathroom really badly, but there's not one there. You're 20 miles down the road. You try to think of anything except your bladder. You sing, you talk, anything but your bladder. Same thing. So your cortex cannot focus on two things at once. So you're going to distract your cortex. So you've gotten your urgency under control, and then you're going to do something to take your mind off your bladder. So you can text someone, you can email, you can call someone. If you're female, you can do online shopping. You can play a game on your phone, anything that makes you think about something else. Here's the way that works. You're taking your brain to another activity. So here's your bladder trying to get the brain's attention, okay? It keeps texting, keeps calling. Finally, the brain's like, cortex here. It's like, it's the bladder. Cortex like, hold please. And the bladder gets elevator music. That's what you've got to do. So distraction works and freeze, squeeze, breathe works. You use freeze, squeeze, breathe to establish control. You use distraction to extend the voiding interval. So you can even set a little alarm on your phone to ring in 20 minutes. And in the meantime, you're playing this game, or you're doing online shopping, or you're sending emails or text messages so that you're not focused on your bladder. Once you get comfortable at a 1.5 hour voiding interval, then you increase it to 1 hour and 45 minutes. Then you increase it to 2 hours. So you see how you're gradually stretching that interval, increasing the interval, increasing capacity, reducing frequency. It does work. It just takes a lot of support and a lot of focus and a lot of determination. And sometimes it takes medications, which we'll get to in just a minute. If you're teaching someone about a bladder retraining program, they're going to say, well, what do I do at night? Do I do all of this stuff at night when I wake up? No. You need your sleep. You wake up at night, get up and go void. Come back to bed. As your voiding interval increases, as your bladder capacity increases, your nocturia will automatically get better. What about medications? So we had very little to offer in the way of medications when it came to stress incontinence, but it's very different in the field of overactive bladder and urge incontinence. We have increasing numbers of medications. So you think, what is it that makes the bladder contract? Parasympathetic stimulation. What is the neurotransmitter? Acetylcholine. Cholinergic agents make the bladder contract. Anticholinergic agents make the bladder relax. The specific type of cholinergic receptors on the bladder wall are muscarinic receptors. So anticholinergics will cause bladder relaxation. Antimuscarinics will cause bladder relaxation. Now, the drug that's been most widely used for the longest period of time is oxybutynin, Ditropan, which is an anticholinergic. Now, the advantage of Ditropan is it's the least expensive, but because it's a cholinergic, it has a lot of side effects. So you've got some of them listed but the most common one in the elderly is confusion, as well as constipation, as well as dry mouth, as well as heat intolerance. So we're very cautious about using ditropan in the elderly population, and a lot of advanced practice nurses just have a rule of thumb: I don't use it. Now, you should know that the sustained release form of ditropan and the transdermal form, the Gelneek gel, have lower incidence of adverse effects. So if you're going to look at using ditropan, you want to think about, can I go with sustained release? Can I go with transdermal? What about antimuscarinics? Well, antimuscarinics are by definition more selective because they only target muscarinic receptors. Muscarinic receptors being a subcategory of cholinergic receptors, but the ones that are important to bladder contraction. So simply by using an antimuscarinic instead of an anticholinergic, you reduce the incidence of adverse effects. Of course, they're much more expensive as well because they're newer. So they're more selective, you have fewer adverse events, you have higher costs. The types of adverse events pretty much the same, but there are a number of your antimuscarinics that do not cross the blood-brain barrier or cross it very poorly. So they're much better choices for your elderly patient because they don't carry the same risk of confusion, delirium. So trospium, tolterodine, solifenacin, darafenacin, all much safer. So anticholinergics, antimuscarinics, very helpful at reducing urgency, reducing frequency. As a category, antimuscarinics safer because they have fewer adverse events, also more costly. What else is out there? Well, we have a new drug. It's a beta-3 agonist, mirabegron. So you say beta-3 agonist. Now, what is that? What would that do? So you go back to neural control of the bladder. We said that sympathetic stimulation tightens the bladder neck, relaxes the bladder wall. That you have one type of sympathetic receptors in the bladder neck, alpha adrenergic receptors. But you have another type of receptor in the bladder wall, beta adrenergic receptors. And beta adrenergic receptors cause bladder wall relaxation. So this beta-3 adrenergic agonist causes bladder wall relaxation. Now remember, it's a type of a sympathomimetic, so the most common side effect is hypertension, which occurs in about 7 to 11% of patients. So we have to be alert for that. And we probably would not want to use this in a patient who had a history of hypertension. But this is another option for medication management, pharmacologic management of overactive bladder. They've also used onabotulinum toxin intravesical, so actually instilled directly into the bladder, injected directly into the bladder wall, and that provides relaxation of the bladder wall, paralysis to partial paralysis of the detrusor muscle for a period of months, and then it has to be repeated. So for patients who don't respond effectively to antimuscarinics, who don't respond or aren't candidates for the mirabegron, we could consider, or the physician could consider, what about botulinum toxin? And I think we have talked enough about topical estrogen. I hope it's now well implanted in your heads that topical estrogen is a wonderful option for postmenopausal women with stress incontinence, with overactive bladder urge incontinence, and that it also reduces the incidence of UTI in elderly women. Pelvic muscle exercises, we've talked about why they're beneficial for the patient with overactive bladder, because when you effectively contract the pelvic floor, you send a message to the bladder that says relax. So the last thing I wanted to mention as a treatment strategy for overactive bladder and urge incontinence is neuromodulation. What do we mean by that? Well, this is therapy that actually modulates the nerve impulses to the bladder. And what is it that makes the bladder contract? Well, it's nerves that make the bladder contract, specifically parasympathetic nerve pathways that control bladder contractility. So the concept with neuromodulation is if you fail to respond to other therapies, we can implant electrodes that control or that modulate parasympathetic inputs to the bladder and make the bladder less contractile, and therefore reduce urgency and reduce frequency. So there's actually two types. There's sacral nerve stimulation, SNS. The trade name is InterStim. So what they do is they implant leads and a battery-operated stimulator. And those leads are placed right adjacent to the sacral nerve pathways that cause bladder contractions. So where do those nerve pathways come off? S2 to S4. Where are these leads implanted? S2 to S4. Now this is expensive therapy and not everyone responds, so what they do is they do a two-step treatment process. With step one, they implant the leads just percutaneously, and they're attached to an external stimulator. So it's a simple office procedure. Now, if the patient is able to document at least a 50% reduction in urgency and frequency and in incontinence episodes, then they'll proceed with phase 2, which is to surgically implant the leads and the stimulator. And overall, they're looking at all the data that's available, there's a 70% response rate among individuals with refractory OAB. So do we need more data? Yes. But is this a reasonable alternative for people who have failed bladder retraining and the currently available medications? Yes. The other type of neuromodulation is PTNS, percutaneous tibial nerve stimulation. So this is actually done in the office or the clinic, and it involves stimulation of the tibial nerve, which has been observed to inhibit bladder contractility through mechanisms and pathways we don't really understand. But it's a simple procedure. Nurses can do this, therapists can do this, as well as physicians. The issue is that it requires repetitive treatment, so typically 30 minutes a week for 12 weeks, and then you have to repeat the therapy at intervals. Also, we don't have as much data on effectiveness. Some suggest about 55% response rate. So we need more data on both of these, but I just want you to know that neuromodulation is an option for the patient with refractory OAB. So primary management of the patient with OAB: eliminate irritants, at least on a trial basis, manage constipation, do topical estrogen for postmenopausal women. Consider or at least try bladder retraining, very effective if the patient is on board. So teach them control strategies, teach them to void by the clock, teach them to gradually stretch out the voiding interval. Consider anticholinergic, antimuscarinic medications for our patients who still have significant urgency and frequency. So there's a lot of different drugs out there. If one doesn't work, you can try another. You could also try the beta-3 adrenergic agonist, mirabegron. You could consider referring the patient for intravesical injection therapy with botulinum. So lots of things out there. Sacral nerve stimulation, PTNS, is last resort. And then the last thing we're going to talk about in this class is management of functional incontinence. So remember that functional incontinence is incontinence in a patient who basically has normal bladder function, normal sphincter function. They have major mobility issues or major problems with cognition, and that's why they're incontinent. So certainly you're going to do environmental alterations if mobility is an issue. So I'm going to use that bedside commode. I'm going to look at getting you a walker or a cane. I'm going to look at what kind of clothing alterations I can make. I'm going to make sure you have the right kind of footwear so you can get to the bathroom as quickly and as safely as possible. For patients who have functional incontinence because of cognitive issues, the primary intervention is a toileting program where I take the patient to the bathroom on some kind of schedule and cue them or prompt them to void. The whole goal of toileting programs is to reduce incontinent episodes. Even if I don't make them completely dry, if I significantly reduce incontinent episodes, I'm going to also reduce the complications associated with incontinence. UTIs, skin breakdown, that kind of thing. In order for a toileting program to be realistic in the care setting, the patient has to meet certain criteria. First of all, they have to be ambulatory with assistance. If it takes 3 people to get them to the bathroom, it's not going to work. If I have to use a Hoyer lift to get them out of bed, it's probably not going to work. But if I can walk them to the bathroom, then at least from that perspective, they're a candidate. They have to be able to follow my instructions. When I cue them to void, they have to be able to void at least 50% of the time, or I'm just wasting caregiver time taking them back and forth to the bathroom. And finally, they have to have a voiding interval of at least 2 hours. So if I have somebody who's voiding every hour, it's not realistic for the caregiver to take them to the bathroom, prompt them to void, get them back every hour. So I've got to get them to at least a 2-hour voiding interval. If they're voiding more often than every 2 hours, I've got to try to figure out why. Is it because they're constipated? Are they getting a lot of irritants? Do they have a UTI that I haven't recognized? Do they have atrophic urethritis that hasn't been treated? Should I trial them on low-dose antimuscarinics? I've got to get them to a voiding interval of 2 to 3 hours. And finally, when you put somebody on a toileting program, you have to realize that it's not solo therapy, that they're still going to have incontinent episodes, so they need to be placed in absorptive products and they need to be on an appropriate skincare protocol. So let's talk about the different toileting programs. There's several different types. Scheduled toileting or habit training is very widely used, both in the home, in long-term care facilities, and assisted living facilities. So here you take the patient to the bathroom on schedule. It can be an individualized schedule determined by their bladder chart. That's reasonable in a home care setting. In an institutional setting, that's not very reasonable, so people are typically They're typically toileted every 3 hours. Sometimes every 2, but more commonly every 3. So you've got your schedule. Patient's going to be taken to the bathroom either at 7, 10, 1, 4, 7, or based on a schedule that matches their voiding patterns. When I take the patient to the bathroom, I am going to cue them to void. I'm going to say, I want you to urinate in the toilet now. That means that this program is very much caregiver dependent. It's for patients who lack the cognitive ability to self-toilet but can respond to instructions. That's the patient who is a candidate. And you should know that in long-term care facilities in the U.S., a scheduled voiding program is the standard of care. As long as the patient can be ambulated with assistance, and as long as they can respond to cues to void at least 50% of the time. If they can't, it's not okay to just put them in absorptive products. They must be toileted. Prompted voiding is a higher level program. Here, the patient and the caregiver share responsibility for keeping the patient as dry as possible. Your goals are to minimize or prevent incontinent episodes and to and to increase the patient's awareness of his or her continence status and to increase their participation in the toileting program. Obviously, the patient has to have a higher level of cognition so that when I say to this patient, Mary, are you wet or are you dry? Mary has to be able to accurately self-report and has to be able to actively cooperate with the toileting program. So basically the way prompted voiding works is I go to the bedside, I say to the patient, Mary, I'm back to take you back to the bathroom. You were dry last time I was in. Are you still dry or are you wet? Mary says, I'm dry. I check, I'm like, you're right, Mary, you are dry. That is great. You're doing so well today. So Mary, I'm going to take you to the bathroom. Are you willing to go to the bathroom with me and see if you can urinate? Yes, I'm willing to go. That is great. See, you're doing such a good job. That's why you're staying dry. Okay, let's take you to the bathroom. So I take her to the bathroom and she voids. She gets even more praise. It is the grown-up version of potty training, of toilet training. I make you more aware of your continence status. I encourage you to void on a routine basis, and I give you lots of praise when you do so. So our whole goal is to make them much more aware and to encourage their participation in keeping themselves dry. Now, there's a new program that's been reported in the literature. It's called Functional Intervention Training. It's been used in some long-term care and assisted living facilities, and basically it involves both a toileting program and musculoskeletal strengthening exercises. And what they found is that putting people on a routine exercise program so that they're involved in wheelchair exercises or standing and stretching and other exercises actually increases their cognitive function, their awareness of their continence status, and their ability to participate in a toileting program. We're not going to ask you that, but there's a possibility that it might show up on the certification exam, so I just want you to know what functional intervention training was. And then the last thing I wanted to point out relative to management of functional incontinence is that toileting programs are not a standalone therapy. Those patients are also going to need absorptive products or containment products because they're probably going to have some incontinent episodes. So you think about when you have a child and you're doing toilet training. There's a whole line of pull-up products that are designed to facilitate toilet training. So they're easy to pull up and pull down. They look and feel a lot like regular underwear, but they have absorptive capacity, so if the child has an accident, they can handle it. It's exactly what you want for the patient with functional incontinence who's on a toileting program. You want any product you use to simulate underwear, okay, to pull up, pull down, to feel like underwear, to look like underwear, but to have absorptive capacity for incontinent episodes. And of course, if you have them in absorptive products, they also need to be on a skincare program. So they're checked, they're changed at appropriate intervals, and they're being routinely managed with a moisturizer moisture barrier combination. So most of the time, for most of your patients with functional incontinence, your absorptive or containment products are adjunct therapy. But what if you have a patient who's not ambulatory? What if you have a patient who cannot respond to voiding cues at least 50% of the time? Then for that patient, absorptive and containment products might be solo therapy. So you want to think of absorptive containment products in skincare as either adjunct therapy for a patient on a toileting program or as solo therapy for a patient who's not a candidate. Okay, we're going to stop there today, and then in the next class we're going to review management of voiding dysfunction, management of neurogenic bladder, management of enuresis. And we're also going to discuss appropriate use of indwelling catheters and containment and absorptive products. Thank you.